present, which we launched today, but we'll also use it in a couple of other meetings from time to time, and we'll try to see that we use it as best as possible to advocate for inclusion of HIV. The background of this study is it was, I think, 2018 that we met Malaysian AIDS Foundation in a international AIDS conference, and they had invited me to speak in one of the sessions which was organized by the business coalition there, and it was a pleasure to meet Professor Adiba there, who is the chair of Malaysian AIDS Foundation. We had a nice session there, engaging with a number of companies, and after that we were contacted by the Malaysian AIDS Foundation because they had heard of the work that ILO had done in Sri Lanka, where we did a lot of advocacy work with insurance companies, and we tried to persuade them to include HIV. And we basically did two things. We involved people living with HIV in that advocacy effort, and they made a very important contribution. And we also looked at a cost benefit analysis of how much would it cost to companies, and how would it be, how does it make a business sense for insurance companies to include HIV. And we had some success there, not a great success, but a couple of companies had started looking at HIV and including that. So, and when Malaysia faced a similar problem, they knew about Sri Lanka, so they contacted our office in Bangkok, and they requested if they could work with the ILO and build on the Sri Lankan experience to advocate for inclusion of HIV in Malaysia. And then our office in Bangkok contacted us. I'm happy our colleague Rakama is there in this call, and that how can we work together, because we are the technical department here. The first point of contact naturally was right for the Bangkok office. So we started looking at it and how this work could be done. We developed a terms of reference for this study, and this study was undertaken. The idea was to interview companies, the idea was interview people and see, look at the literature, and you will hear more from the consultants who did this study. So now we have a good study, which is going to be presented today, and we'll also discuss how best to take it forward. So very warm welcome on our behalf in the ILO. But since this study was done in collaboration with the Malaysian AIDS Foundation, I would also request our colleague in Malaysian AIDS Foundation, Andrew Story, to speak for a minute and welcome guests on behalf of Malaysian AIDS Foundation also. Andrew, the floor is yours.
Andrew, you're muted.
Okay, sorry. Good afternoon to all Malaysian friends, and good morning to our colleagues in Geneva. My name is Andrew. I'm from the Resource Mobilization Manager from the Malaysia AIDS Foundation. On behalf of the MAF Secretariat, I would like to thank you for the participating in the official launch of the People Living with HIV Medical Insurance Research by MAF and International Labour Organization. MAF wish to acknowledge the great support from the ILO team in Geneva and Bangkok and the UNAIDS. From MAF, we have our chairman, Professor Dato Adiba, who will also present her viewpoint later. Our special thanks to Dr. Anita Sulaiman, the head of HIV sector at the Ministry of Health, and all the stakeholder friends. Ladies and gentlemen, this landmark report is commissioned by MAF to provide an objective assessment and review about the state of health insurance coverage for people living with HIV in Malaysia, which we reckon remains a major barrier of entry of people living with HIV in workplace. We also looking forward to hear the policy recommendation that comes with this report and how to move it forward. Our collaboration with ILO is driven by the Malaysian Business Consortium for HIV/AIDS, MBCH, which was established by MAF and supported by corporate allies and key stakeholders, such as Ministry of Human Resources and the Ministry of Health, to create HIV-friendly business and legislative environment. I now hand over to the session to Mr. Afsar Said Mohammed, the Senior Technology Specialist of Gender Equality, Diversity and Inclusion from the International Labour Organization in Geneva. So the session is yours. Thank you.
Thank you very much, Andrew. And I would welcome all of you once again and request Manuela Chome, Director of Conditions of Work and Equality Department here with the ILO in Geneva. Manuela, thank you so much for joining in, and I request you to please share your opening remarks. Thank you.
Thank you very much, Afsar, and good morning, good afternoon to everyone. It is my pleasure to join in the launch of this study on medical insurance coverage for people living with HIV in Malaysia. The study couldn't have been more timely. The current COVID-19 pandemic has generated a major health, social, and economic crisis everywhere. And while the virus makes no distinction among social groups or between the rich and the poor, its effects have been highly uneven. The over 37 million people living with HIV, disadvantaged already before the pandemic by stigma, discrimination, and marginalization, are amongst the hardest hit. And they have been affected in three major ways. They are losing jobs and livelihoods. Around the world, people living with HIV exhibit a high unemployment rate compared to other groups. And when they work, they do so often in the formal economy. According to the latest estimates of the ILO monitor, 1.6 billion of the 2 billion informal workers globally have suffered severe economic losses following the introduction of lockdown measures and other confinement measures. With no or limited access to health services or income support, the negative effects of these job losses on the households and livelihoods of people living with HIV are likely to be long-lasting. They are also experiencing serious disruptions in HIV testing and treatment. The risk of antiretroviral treatment stocks running out is high in several countries due to lockdowns and supply chain disruptions. And from our interactions with people living with HIV and other actors, we gather that HIV prevention and testing services have slowed down. Those who test positive for HIV may not access antiretroviral treatment immediately because health facilities are fully engaged in dealing with the COVID-19 emergency. But people living with HIV are being failed also by social protection systems. The majority do not have adequate access to social protection. And even though in a number of countries they receive free antiretroviral treatment paid by governments and donors, many still struggle to cover their out-of-pocket healthcare expenses. This proves even more challenging in the current pandemic. Further, an ILO study on access and effects of social protection on workers living with HIV and their households that was carried out a couple of years ago shows that even where social protection covers HIV, people living with HIV and key populations find it challenging to access services. There are three top barriers that they face. These are stigma and discrimination, lack of knowledge about the existing programs, and the complicated procedures for accessing such schemes. This tells us very clearly that the mere inclusion of HIV in social protection policies is not enough. Social protection programs need to be HIV response and address these three barriers. The COVID-19 pandemic has exposed the pervasiveness and seriousness of pre-existing inequalities and made apparent the cracks in social protection system. Delivering on the promise of the 23rd Agenda for Sustainable Development of leaving no one behind, and on the SDG 1 commitment of implementing nationally appropriate social protection system and measures for all has never been as urgent as today. We have a long way to go though. According to ILO's data, before the pandemic, and more specifically in 2019, only 27% of the global population enjoyed adequate social security coverage, while 40% had no access to health insurance. This is why we congratulate UNAIDS for the recently adopted new global strategy on AIDS and its emphasis on integrating HIV response into national systems for health, social protection, and in humanitarian settings. We also very much welcome the attention the new strategy pays to tackling inequalities that drive the HIV pandemic. This is something new and very welcome. This brings me to the study that we are launching today. Antiretroviral treatment permits people living with HIV to conduct healthy and productive lives. It would be sensible to include them under the coverage of public and private health insurance. This is the main message of the study before us, a message which is in line with the call on member states of the ILO recommendation on HIV and AIDS and the World of Work, recommendation number 200, to ensure that workers living with HIV and their dependents benefit from full access to healthcare, whether this is provided under public health, social security systems, or private insurance or other schemes. The study, as we heard, is based on a wealth of data and information from also other parts of the world and draws upon the results of interviews to relevant Malaysian stakeholders. The purpose of this report is to provide a basis to stimulate and inform national dialogue around the desirability and viability of extending medical insurance coverage to people living with HIV. I would like to thank very much the Malaysian AIDS Foundation for undertaking this very important research in collaboration with the ILO. And I'm also pleased to see key national stakeholders from Malaysia. I think we also count on the presence of representatives from the Ministry of Health in today's meeting. Welcome. This is very encouraging and confirms the timeliness and relevance of the study before us. So I look forward to today's deliberations on how to make health insurance more inclusive, leaving no one behind. Thank you very much for your attention, and over to you, Afsar.
Thank you very much, Manuela, for your intervention and for highlighting some very important points which would really guide our deliberations today. Manuela has drawn our attention towards the SDG pledge of leaving no one behind. This is one pledge that we need to constantly remind our stakeholders as we talk to them, because whether they are looking at any issue, and they need to look at the people who are being and reach those who are furthest behind, not just those who are ultimately covered in some scheme or the other. And that's what we see when we look at social protection. They do reach some people, but when this pledge was adopted, the idea was that governments should make an attempt to identify who are being left behind, where are they, where do they live, and go to the remotest corner in your country, identify and do it in consultation with the peoples. So whether they are people living with HIV, people living with disability, migrant workers, indigenous and tribal peoples, women and girls, youth, the list is endless, but it's for the countries to identify who is being left behind in their own countries. This message we want to kind of reiterate from time to time as we pick up this issue. And it's also, and the second point related to that, you need data, you need information about them. Who are they, where do they live, what is their number, and what stops them from accessing services. And that's where the second point that Manuela made about the bottlenecks or the challenges people face in accessing the existing schemes are three. One is the stigma and discrimination, which is continuing, unfortunately, despite years of work. Second is complicated procedures, which are there for people to access those services. Give you one example. In one country, when we did another piece of research, there's a format where people have to write their sex, and those who are transgenders, they don't know what do they write there. And so they face problems at the very first stage. And the third issue is the lack of awareness about schemes which exist for social protection, social security, social health insurance. So these points are very important, and I'm sure today's discussion would help us carve out our advocacy messages rather clearly and lead us for taking up a program which will be useful not just in Malaysia but in other parts of the world. So thank you very much, Manuela, for raising that and also drawing attention towards the new UNAIDS strategy. We will hear a little bit more about it from our colleague David Chipanta, who was joined in the call, and we are very happy to welcome him as well. So now I would go and request Professor Adiba Kamarul Zaman. Professor Adiba is the chair of Malaysian AIDS Foundation. She is also the president of International AIDS Society, which will be organizing the conference, International AIDS Conference. It was my pleasure to meet her in the last conference and again in Malaysia when we were launching this study. We were having the validation workshop for this study with colleagues in Malaysia. So Professor Deepa, thank you so much for your participation, and I request you to please come in and make your remarks. Over to you.
Thank you very much, Afsar, and good afternoon and good morning, dear colleagues. I'll just make my intervention brief because we really want to hear from Dr. Kana and Sharuna their findings from this very important study. As Afsar said, it began with a conference that the International AIDS Conference in Amsterdam, where we showcased some of the work that companies here in Malaysia were doing to support the Malaysian AIDS Foundation and the work at the Malaysian AIDS Council in general. And this idea to then do this research came about, as you heard, from a previous work that Afsar and the ILO have done, because we felt that it's a very important piece of research to find out exactly what is happening in terms of social protection for people living with HIV, but also as an important advocacy tool, because believe it or not, 4 decades into the HIV pandemic, many people in Malaysia are still unaware that there's effective treatment. People can live a normal, productive life. I think in many minds, AIDS is still a death sentence, and so we hope by having this report, we can go to some way in dispelling some very basic information that contributes to the stigma and discrimination that's still so pervasive in Malaysia and in the region. I'm just very happy to be able to bring 2 organizations and the ILO that I'm closely linked with, the International AIDS Society, and the conferences that we host to do this important work. At the IAS, we've also just launched our strategy, and we firmly believe in science, people, and progress. That I think we very much encourage the use of science through the conferences that we convene and our journals to hope that they will impact on policy. And this is exactly what we wish for this study to do. And like what you've heard from Manuela in terms of the importance of not leaving anyone behind. Unfortunately, many of those affected in Malaysia, well, by virtue of them being people living with HIV, they're already stigmatized and left behind. But the key populations who are at risk or have been infected are doubly jeopardized and doubly stigmatized. So all of this research and the ability to educate the public and hopefully the insurance sector of how HIV is a different disease, it's a chronic, treatable condition, is going to be very, very important moving forward. So once again, thank you very much to Afsar and the entire ILO team, and of course to the team at MAF for being here today, and also for this report. And I'm looking forward to hearing the presentation from Kana and Sharuna. And after this, we will work with the Ministry of Health to advocate to our key stakeholders, namely individual insurance companies, the Association of Insurance Companies in Malaysia, most importantly, the Central Bank of Malaysia, which actually regulates the insurance industry in Malaysia. And I think it's in everybody's interest to support people living with HIV through insurance because, to ensure that they, like everyone else, can lead healthy, productive lives. So with that, over to you, Afsar, and thank you once again.
Thank you very much, Professor Adiba, for your remarks. Very, very grateful that you are here in this call. And also you have articulated your plans to follow up with Ministry of Health and also with insurance companies to take forward. This was exactly the recommendation when we launched the preliminary findings of this report and had a validation workshop in Kuala Lumpur. A number of action points were identified, and this certainly was one of them. I know because of COVID, everything has become a little difficult, but it's always good to remind ourselves that we have to do those meetings. And there were a lot of insurance agents, insurance company representatives present in that meeting. Interest in about it and participating in further discussion, so that would be important. So with this, now I would invite and also first of all thank Dr. Sharuna Verghese and Dr. Kanalaningam for taking this research. As researchers, they did a lot of hard work in doing all the interviews, in doing the literature review, and I must admit that it was not easy, because it's not easy to contact an insurance company and ask for an interview for this kind of work. We tried. I'm fully aware of the effort they made. We also tried to help from our side as much as we could. But at the end of the day, they were able to interview people. They were able to do a good literature review and write such a nice report. So thank you so much, Dr. Sharuna and Dr. Khanna, and over to you to make your presentation. You can unmute yourself.
Yes, thank you very much, Mr. Afsar. Just let me get the slides on. Can you guys see the slides now?
Yes, we can.
Excellent. Okay. On behalf of Dr. Sharuna and myself, first let me thank the ILO and the Malaysian AIDS Foundation, both organizations of which have done a lot of good work, including in the field of HIV and AIDS. And this effort is a testament to the cooperation and coordination between two organizations and what can be achieved. I would also like to record the appreciation for the Ministry of Health of Malaysia. For decades, treatment and management of HIV has been provided for free. And in fact, recently there have also been efforts to decentralize management of HIV to clinics and make it more accessible to the population, particularly to key populations who are marginalized and stigmatized. So to go on to the first set of slides, Dr. Sharuna.
Yep. Thanks, Khanna. I think I just want to also preface the start of the presentation by acknowledging Dr. Yap Kwang Sia, a public health researcher from the Jeffrey Chia School of Medicine and Health Sciences, Monash University, who was part of the research team with Dr. Khanna and myself. So we had three major objectives for this study. The first was to determine factors related to the provision of private health insurance coverage or the lack of it by private insurance companies in Malaysia. The second was to examine the barriers to private health insurance and healthcare financing consequences that arose out of such a situation for people living with HIV in Malaysia. And we also wanted to review good practices with regard to private health insurance coverage for people living with HIV in developing countries, with a particular focus on Southeast Asia, in order that we might be able to generate recommendations. So in terms of the methods, it was a qualitative study. We did a scoping review review of literature and document analysis, which covered several themes, from looking at the current state of treatment and management of HIV to the various other topics of this research that have been identified in the objectives. 2 focus group discussions with people living with HIV. We did so we had 14 in-depth interviews with people living with HIV, 2 in-depth interviews with employers from the corporate sector, 11 in-depth interviews with representatives from the insurance sector, and 2 infectious disease physicians. We also ran a qualitative survey with 11 insurance companies, and we had several meetings with different government agencies, and we triangulated all this information to put together the findings. So Dr. Khanna will take over from here for the next part.
Dr. Khanna, you're muted. Dr. Khanna, you're muted.
Can you hear now?
Yes, thank you.
Excellent. Apologies. So, as I was saying, so we started off looking at the treatment and treatment and management of HIV in Malaysia, as well as comparing it to the guidelines, international guidelines. So in Malaysia in 2017, the Malaysian Society of HIV and AIDS Medicine, together with the Ministry of Health, came out with consensus guidelines for treating and managing HIV. And we compared this with the WHO consolidated guidelines for antiretroviral treatment of 2016. And what we found was that the first-line treatment and second-line treatment more or less were comparable both locally as well as following the international guidelines. And given the local availability of the drugs, also starting the medication for people with HIV. Now the guidelines are to start treatment for people who have HIV, adults who have HIV immediately. We don't wait for the CD4 levels to start going down. And these are in both guidelines, both locally and internationally, as well as different parameters that are used to follow up people with HIV using CD4 levels and viral load levels were both also similar. And as I mentioned, in Malaysia, treatment is given free or subsidized by the government. So generally, the treatment outcomes for treatment of HIV in Malaysia is comparable to what is seen in international studies as well. Most of the patients achieve viral load suppression. In fact, in the treatment centers in Malaysia, about 90% of patients on treatment achieve viral load suppression. We also had a discussion with people who are living with HIV to give their point of view. And so we discussed with them on a number of issues, including the status of their infection and how they were managing. And we found that of the 14 people that were included in the study, the ranges of having HIV, some were diagnosed as far as 25 years before the study, and some just 11 months of the study. Now, all of them had viral load suppression. And most of them were in the productive age group. of between 20 and 50 years of age, and most were male. All were working in different sectors, in the government sector, in the private sector, and with NGOs as well. But what we found was that the treatment, for those who start treatment, the outcomes were very good. As mentioned, as Mr. Afsar mentioned, it may have been a challenge to approach insurance companies, but we found that some of them were quite willing to discuss, and they were actually open to, when approached appropriately, they were open to finding out more about HIV and treatment, current treatment for HIV and the outcomes as well. Now, in the questionnaire, what we found was they have a blanket exclusion policy for HIV. And so, by and large, people who have HIV are not eligible for insurance coverage. And those who have existing insurance policies as well, they will then have the policy terminated and or will not be able to claim. And this, of course, depends on the policy wording. We found that companies were not really, among the companies that we did the survey, they were not really aware of the current outcome of HIV and the current status of the epidemic in Malaysia. They had not really done any studies to assess these, as well as the health outcomes. However, in the study, we found that a number of the companies express willingness to cover HIV, but there were certain criteria they would look at, like is the person on treatment, is the viral load suppressed. They looked at other comorbidities. They were willing to look at these, as well as other lifestyle issues like smoking and things like that. So by and large, the insurance companies were not aware of the current status, but they were willing to look into it. We also had interviews with people who are living with HIV to see their experiences. So the experiences we discussed with them, this was through in-depth interviews as well as focus group discussions. We looked at the state of their HIV and the treatment. We looked at their whether they were working or not, and we also looked at their experiences with insurance companies. So as I mentioned, most of them were in their productive age group, and almost all were working, including the two women who were included in the study. As far as group insurance, so some of the issues that were brought up during the discussions in relation to insurance was that for those who were working, because work-based medical coverage was related to the ability to find a job. Like, for example, when they applied for a job or they were going to get a promotion, then they were required to do a medical examination. And often this was because this is a requirement for the insurance companies that covers the group insurance at the workplace. And so this was a barrier. Often they would, when they found out there was a medical checkup to be done, they would either opt out or they would either not apply for the job or opt out of the promotion. So this was a significant barrier to employment. There were other issues that came up as well. For example, when they applied for housing loans, then there would have to be mortgage reducing time riders, which are insurances taken against the loan. And often these require medical checkup as well, in which case their HIV status may have been revealed. And there were clients who actually had loans, there were interviewees who had loans rejected, although they went on to buy the house and successfully paid it up. So they mentioned that this is a loss to the insurance company. But there were also other cases where people who presented to the hospitals, tried to claim insurance, but then were rejected, and so they had to go to government hospitals, or even had to then pay out of their pocket. There were even cases of people who passed away, but couldn't claim the insurance because their dependents couldn't claim the insurance because of the HIV status. So this had a significant impact of people living with HIV. Dr. Sharuna?
Yeah, thanks, Kanna. So for the next part, we will be sharing the findings of the review of country case studies that we did, looking at private medical insurance coverage for people living with HIV. If you look at the report, the way that we approached this review was to review it within the context of the overall healthcare financing in the different countries that we selected, in order to be able to contextualize the role and the significance of private medical insurance in HIV financing. We won't be going into all those details here, but focusing on the broad findings. The choice of the countries was actually guided by the proximity to Malaysia. So we have the ASEAN countries like Philippines, Thailand, and Vietnam that we decided to look at. And then we also looked at the availability of private medical insurance for HIV in countries where there was a long established practice, but also in countries in the global south. And if you look at the countries, you will see that they range from countries in Africa, Asia, as well as Latin America. I think broadly what we saw is that in countries which have a strong universal health coverage as well as social insurance, generally the use of private health insurance is low. But it is a complement. In certain countries, it was found that where there was strong social health insurance, that employers actually used private health insurance in complement with other payroll benefits. So the broad findings that actually emerged is, first of all, that the recognition on the part of the insurance companies that HIV was a chronic condition, and this was from multinational insurance companies both in the global north as well as the south. In fact, the chief underwriter from a country in North America actually said we didn't do it because there were large numbers, but rather because we considered HIV to be a chronic disease and not life-threatening. In fact, this company went on to provide coverage even without a reinsurer. But we also saw a similar narrative from a leading insurance company in South Africa, which said, we recognize that HIV is a disease similar to any kind of chronic disease that has certain outcomes. In fact, they said more favorable outcomes than some other diseases if it is well controlled. And this decision and this perception of and the recognition of HIV as a chronic condition was, also based on the review of the kind of treatment outcomes and the evidence that is available in relation to treatment outcomes for those who are adherent to antiretroviral therapy. And generally, as Dr. Kanna said earlier, the insurers said that they found from their own analysis that especially when the CD4 count is low, there's viral suppression, the initiation of care was early, or treatment was early, the diagnosis was early, that generally they found that, there were positive, good health outcomes for the people that they were covering. And so those advances in treatment regimens and consequences, here we have cited the case of Sri Lanka because there is a published report, but this also came through from the narratives of the in-depth interviews that we did with insurers in some of the countries. And the positive health outcomes in turn were linked to the availability of free and subsidized antiretroviral therapy. And especially in countries like Kenya and Uganda, we found that it was the availability of this free or subsidized ART that actually modified the risk perception of private insurers, and they began to cover people living with HIV with private medical insurance. But as we all know, historically, the availability of free and subsidized ART was also a process of struggle. And the insurers also acknowledged this, especially countries like South Africa, the constitutional guarantee of the right to health in the South African constitution, and the role that was, played by the people, the participation of people living with HIV in asking, for this access to treatment played a big role, and the insurers actually acknowledged that. And we also see similar narratives from insurers in Kenya, where, there is a law that prohibits discrimination against people with HIV, including, asking them to take an HIV test before providing for covering them for insurance. Closer home, we did an interview with the office of one of the senators who had moved the Philippine HIV and AIDS Policy Act, which became effective in January 2019. And this is a bill that explicitly prohibits discrimination against people with HIV, and discrimination especially in accessing screening, treatment, prevention. And it makes a provision in PhilHealth, which is the social health insurance program in the Philippines, to actually develop a package of benefits related to HIV. So we also saw the salience of legislation and policies that was important in actually opening up the channels and the diverse sources of healthcare financing that could be available for HIV. And in a way, these narratives also tie into the actuarial analysis that companies shared with us, which was based on scientific evidence. And so they stated that it wasn't like the old times, where there was no information available. In fact, based on robust population-based studies, they found that there were several indicators from epidemiological studies, which actually provided them enough data to be able to make those risk assessments. And prominent among them were the CD4 count, viral load, route of transmission, comorbidity, whether it was an early diagnosis, how long has the applicant been on treatment, treatment adherence, age, gender, occupation, and of course, lifestyle factors. And I think these are indicators that, today is this kind of information is easily available for insurance companies that might be, exploring this idea of covering people living with HIV with private medical insurance. We also found that social health insurance played an important role, and especially Kenya is a good example, where the employers, in addition to the payroll-based social health insurance, they decided to also purchase private health insurance to cover their employees for HIV. And so it also shows how certain healthcare financing systems can work in tandem. Now, I think we have to also look at it quite carefully, because there is also the Wagstaff, study that was done with the World Bank, which also has, come up with certain conclusions about in relation to equity and social health insurance. But notwithstanding that, I think it has shown that there is a possibility to open up another form of financing. And finally, of course, the role of philanthropies like the Global Fund and so on, which made antiretroviral treatment free or subsidized and accessible. And this was especially in countries in Africa, Kenya, Uganda, and so on, which then in turn prompted insurance companies to open up medical insurance for people living with HIV. Kana, can we have the next slide? So if we look at the global evidence and we look at the scenario in Malaysia, the research team found that the case for extending medical insurance coverage for people living with HIV in Malaysia is actually good, because if you look at the first factor, which is the availability of free and subsidized antiretroviral treatment, we see that it is not only that it is in line with international guidelines, but the government has taken several measures actually to make it widely accessible by and it has taken several steps in terms of lowering drug prices, encouraging local HIV drug production, and also using strategies such as compulsory licensing to expand access. The government has also integrated HIV into treatment into primary care, has stepped up the training of family health physicians, their training in HIV, and it also invests in treatment adherence peer support. So there is robust, strong support from the government in terms of making it free, subsidized, accessible. And so that's a good opening for insurance companies to consider to cover people living with HIV. We also saw from the research, as Dr. Khanna presented, that overall there was a stable CD4 count and viral load suppression. In fact, out of the 14 in-depth interviews, except for one who was newly diagnosed, everybody else had an undetectable viral load. And the review that we did of studies which focused on a survival analysis actually showed that wherever they were adherent to treatment and there was an early initiation of care, then health outcomes and life expectancy, was close to that of the general population. The study also shows us that it's not that we are operating in the dark, that there is a solid analytical framework that is being used by insurance companies overseas to mitigate and distribute risks. And so in relation to that, in discussing that with local insurers, a couple of issues came about. The first is that the insurers, they opine that if the government actually signaled that this is something that we would like to do for the country, that they would actually fall in, and the advantage of that would be that it would increase the pool of those who would be covering the insurance, and therefore the risk would be lower. Also, the people living with HIV said that rather focusing on just medical insurance, actually diversifying the products and allowing them to also purchase life insurance, housing, and so on would be another way of diversifying risk. And overall, what emerges is that it is a lost business opportunity for the insurance sector. Especially because, as we saw even through the research, that the people that we had interviewed had survived a long period of time, over 2 decades, some of them 2.5 decades since the time of diagnosis. So it's a lost business opportunity. Finally, the case for extending medical insurance coverage relates to addressing out-of-pocket payments for healthcare in Malaysia. Now, if you compare Malaysia with the neighboring countries, generally there is equity in this, in the sense that it is progressive. It is more of the rich who are, incurring these out-of-pocket payments, but yet it is quite high. The out-of-pocket payments make up about 38% of total expenditure on health, and also 77% of private sources of healthcare financing. And for a country like ours that is committed to universal health coverage, and universal health coverage being focused on really providing financial risk protection, reducing the out-of-pocket payments, and finding as much as possible a solution in terms of prepaid options, then this is also a very strong reason. And while out-of-pocket payments in this country might be associated because of the rise in NCDs, nevertheless we are talking about also PLHIV in this country, who are saying that a lot of their out-of-pocket payments are also coming for non-HIV related treatments. So we see that there is actually a solid and a good basis for beginning a dialogue on how whether we can and how we can actually extend private medical insurance coverage for PLHIV in Malaysia. Thank you. Khanna?
So I'll just finish off with the recommendations, just 2 slides. So based on the findings from the studies that we did, we came up with a number of recommendations. So the first and the most important recommendation is, among the stakeholders that we spoke to, which is the different government agencies, even the insurance companies, they were willing to sit down and talk about the issue and discuss what can be done, but they were looking for leadership, for somebody to coordinate. And because this is a HIV/AIDS issue and it depends on the treatment and outcomes of HIV, mostly they were looking at the Ministry of Health. So it would require a high level of leadership from the Ministry of Health to coordinate and facilitate discussions of stakeholders. We also found that there were a lot of issues that were faced by people with HIV with regards to insurance, and it doesn't seem as though this has been well documented and understood. And so including the voices of people living with HIV in the discussions were very important. It would also help to find out their needs, and then if these were addressed, then they would actually participate in the insurance companies' insurance policies, which would then make it viable as well. Based on the paucity of research, both, especially locally, of the outcomes of people living with HIV, given the current improvements in treatment and management, as well as the needs of people living with HIV and the challenges that were faced. So cooperation and dialogue between government, insurance companies, health research communities are important to come up with the required information. Because work-based insurance is very much tied to employment, we recommend that employers and insurance work together to review and expand the work-based group medical and health insurance for HIV. And lastly, the issues faced by people with HIV were not only related to medical insurance or workplace insurance. There were other things like providing for their dependents after they pass on, insurance coverage related to purchasing of houses, even issues of insurance as a savings for the future or for studies for young PLHIV came up. And therefore, we recommend that consideration be made for the exclusion of HIV to remove from all insurance products in the future. Thank you very much. Back to you, Mr. Afsa.
Okay, thank you very much, Dr. Sharuna and Dr. Khanna, for such a rich presentation. Very insightful. You covered quite a lot in your few slides that you have just shown. I see there are lots of questions and comments in the chat box already coming in. So I request you to please take a look at them and we'll come back to you to respond to some of them if possible. Of course, there are some questions which are a little bit beyond the scope of this research, but they're extremely important. One is about domestic financing for antiretroviral treatment. I'm sure David Chipanta, when he speaks, could respond to that. But the issue is, yes, there's a case for it, and a number of countries have already taken these steps to enhance their own funding for providing antiretroviral treatment at their own cost. And as far as I understand, if I recall correctly from my discussions with Ministry of Health colleagues when I was there in Malaysia, they're also picking up costs quite a lot on their own. So that would be one thing to keep in mind. There's also an experience shared from colleague Rajesh in Nepal, who is actually an indigenous person, who's done a lot of work on HIV, and he's sharing his experience. He did a lot of advocacy, and now they are getting free health insurance for all people living with HIV since 2020. So advocacy does help, and it makes a contribution. So please go through the chat and pick up the question that need to be answered. We'll have some time to respond to them. But for some questions, please also write your answers in the chat. That's what I would request to you, Dr. Khanna and Dr. Sharuna, if possible. So now I will invite our colleague from UNAIDS, David. Thank you very much for joining in. David is a senior advisor with UNAIDS. He's dealing with social protection an extremely important area which would certainly cover social health insurance. So David, over to you for your brief intervention. Thank you.
Thank you very much, Afsa, distinguished ILO Equality Director, Ms. Manuel Tomeo, Professor Adeba, the President of the International AIDS Society, the researchers, Dr. Sharuna and Dr. Kanagalingam, Dr. Anita Suleiman, distinguished speakers and participants. Can you first confirm that you can hear me?
Yes, we can hear you.
Thank you very much. UNAIDS is really excited to join you on the launch of this important document. Maybe we start from the beginning, which is the SDGs. Access to medical insurance coverage for people living with HIV is actually at the heart of several SDGs, and it finds its home in SDG 1.3.1, which is to implement nationally appropriate social protection systems and measures for all, including floors by 2030, when we hope to end the AIDS epidemic. It is also connected to SDG 3.8, which is achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines. And it's definitely connected to several other SDGs. So the work of the ILO, as represented in the ILO 2018 World Social Protection Report, shows that only less than 50% of the global population received at least one form of social protection floors, including medical cover. And our work as UNAIDS in 4 high HIV prevalence countries of Eastern and Southern Africa, covering Eswatini, Malawi, Tanzania, and Zambia, shows that people living with HIV access social protection services, including medical cover, more or less at the same level as the general population. But still, it's below the 45% global coverage of social protection floors. Really of concern, we find that key populations, including sex workers, men who have sex with men, are not accessing that much of the social protection floors, including medical cover, showing that many of the systems that we have in place can and do leave out people that are already excluded. So while a rising tide in coverage is important, it does not lift everyone. Key populations generally are left behind. As we heard from this research, we need to strengthen universal social protection systems, looking particularly at government funded and provided systems. And at the same time, we need to strengthen the private insurance market to supplement and really find ways to cover pockets of people that are not that are left behind. But private insurance companies, they cannot replace universal systems. So universal systems should be our focus, and then the private insurance can reinforce these systems. We have to strengthen partnerships, as we heard from the research, with our policymakers. The central bank, who we heard from the professor, who regulate the insurance market, the ministries of health, as we heard from the research from the researchers, and the actual researchers, and the communities to help us understand who is being left behind and what can be done to include them. UNAIDS, AFSA, and distinguished participants is really interested in this area. And from the social protection angle, social protection is quite prominent in the work of new UNAIDS, and also in the new UNAIDS strategy. It is under priority area 3, result area 9. And it's also reflected as a cross-cutting issue. So this prominency helps us to find ways to work with ILO and your constituencies to strengthen the coverage of people living with HIV and key populations in broader health systems. Our director, Ms. Winnie Bianima, the UNAIDS Executive Director, and UNAIDS top management are really keen to advance, to end inequality by ending inequality in accessing social services. They are very keen to work closely with you to really bring long-lasting changes and linkages of people living with HIV to broader social protection and health coverage systems. Thank you so much, and I look forward to learning more about this important work.
Thank you very much, David, for participating and making your points very important, that you highlighted the role of universal health care system, and the role of government is extremely important in expanding the reach, and the private sector certainly has it. So we are basically looking at a scenario where each partner plays its role so that we have a good comprehensive coverage for people. Now, David, you can also look at the chat box and perhaps one or two questions you could respond to, particularly with regards to the domestic financing, and how much it's on the rise, and if you have any specific information to add there, it would be useful. Now I would invite, let's hear the community perspective. It's so important in this research because we are talking about coverage of people. And so I would invite Andrew Tan, who's the president of Kuala Lumpur AIDS Support Services, who is with us in this call. I would like to ask Andrew to come in and share his views briefly. And in particular, what does this research mean to you, to people who need to be covered, and how would it help you? So please come in, Andrew. The floor is yours.
Thank you very much. Thank you very much, and good day to everyone across the world. Can everyone hear me all right?
Yes, we can hear you.
Okay, thank you very much. I am a person living with HIV since I found out in 1994, and my survival rate basically has been mainly due to the excellent work by my doctors, who have provided me treatment for almost 3 decades. And so what I've realized over the years is that with the advancements of medication, with the top quality information that the doctors have, and not only that, but with the accessibility of treatment, especially 1 pill a day or even 2 pills a day, as we use in Malaysia, is very, very much different from the early days of treatment, when I faced taking almost 20 over tablets per day, and medication was not supported by the Malaysian government, and I had to fork out about 2,000 ringgit per month just to stay alive. And so being grateful to all the doctors, medical personnel who have allowed me to survive for so many years and thrive and have a opportunity to give back to society. I also realized that it is important to speak out about what is lacking in terms of our access to services like insurance. So what we were thinking was that in April of 2019, I was invited to give a talk at one of the health and living programs by a radio station. And one of my comments during that time was on the lack of insurance coverage for HIV positive people. And I made a joke to say that if anybody had actually sold me a policy back in when I was diagnosed, they would have made so much of money that because I never had an opportunity to fall ill because of the excellent work by my doctors and nurses. So they would have made a ton of money from me, and I would not have had any reason to claim it. And going back to the data that we have right now in Malaysia, we have about 88,000 people who are still living with HIV and surviving. And if we were to do a rough calculation of insurance coverage for someone at maybe $1 per day, that value of premiums that an insurance company, of course, would look at in terms of profitability would come to about, based on a survival rate of about 20 years or 30 years, right? It would come out to over 1 billion. And that's just on $1 per day. And can you imagine if people were to invest more in that insurance policy, the potential of that kind of coverage for the people who actually need it is incredible. Because insurance policies, insurance companies, we realize, actually base on their risk factors as well as their profitability, because they do have management who wants to make sure that the company does make profit, and they do have shareholders that want to see a return on their investment. So if we approach and we speak to them logically about the benefits in terms of returns to the company, I'm sure they would be more than willing to sit up and take notice. So thank you very much for this initiative, Malaysian AIDS Council, and to the researchers. Thank you very much for ILO for the support and all the related organizations around the world. That's all for me. Thank you very much from Malaysia.
Thank you so much, Andrew, for making your points and making such a strong and such a clear statement that how much insurance companies will be losing by not covering HIV, because with the increased survival rate and people will be paying premium for 30 years, 40 years. And so there's a huge market there. That's so important. There's one question that I see in the chat and I want to ask you, because I think you're the best person to respond to that, is if you get free antiretroviral treatment, why do you need health insurance?
I believe the insurance policy actually covers us for other things that are not related to HIV, because if governments around the world are already supportive of HIV, providing basic HIV treatment to anyone who is living with HIV, that would definitely allow the world to actually end AIDS by the targeted dates that we have agreed upon. And because as long as each person who needs treatment is on treatment, they can no longer pass the virus to anyone else. And what you actually end up getting is fewer and fewer people infected with HIV, as more people are undetectable based on the U equals U concept. Fewer people will get infected with the virus, and fewer people will need to go on treatment. So there is a cost benefit throughout for the governments who are actually supporting HIV treatment for their citizens as well. And at the same time, it protects us, it gives us a peace of mind, because if there was something else that happened to me, in terms of something unexpected like an accident or an incident that has no relation to HIV, I would still be able to have the opportunity to select a treatment center that is suitable for that ailment or for that condition, rather than being very limited in my choices. So I think to afford that kind of choice to PLHIV is an incredible benefit. Thank you very much.
That's good. Thank you so much. Do you have things like, can you make a statement about how much is out-of-pocket expense that you have to incur for your other health conditions? Because if you are excluded from insurance, the out-of-pocket expenses are extremely high. You may need to go to a doctor and pay the consultation fee for other illnesses. So is that a burden? Because that's what we hear from other discussions, that there's huge out-of-pocket expenses that people living with HIV have to incur, and that's why they need health insurance as well.
I think the most important thing with HIV is, of course, the prevention is undeniable, but in terms of test and treat that many countries are on board with, so it begs the question all the time, why should I test if there is no treatment available? So if there is antiretrovirals that are advanced and can suppress the virus, if there is an opportunity to test and treat, basically all the rest of the peripheral medical requirements are almost negligible. I will tell you that for myself, other than the normal cough and colds, which I would probably need a paracetamol or my cough medicine for, I have not fallen ill for, touch wood, fallen ill for a long time. And I have not needed any hospitalization or any other coverage or support for anything that severe. So maybe I'm on one end of the spectrum because I try to take good care of myself. But that goes to prove that if someone is committed to taking their medication every day for as long as it takes to maintain their high level of CD4 and undetectable viral load, there is no danger at all. And because we follow up regularly every 6 months, every 1 year, and our good doctors do our full blood work, our liver function tests, our renal function tests, everything on board, they always spot problems even way before it becomes a problem. So they give us our warnings to say, oh, your cholesterol is a little bit high. And with that kind of warning, we learn how to take care of ourselves. And we make changes in our diet, we make changes in how much exercise we get. And basically, our survival rate is we probably outlive everybody around us anyway. So so anyway, the most important thing is that there is a knock-on effect for every single health requirement out there, because people are not going to be getting sick because they get regular follow-ups, regular treatment, and regular blood tests. Thank you very much.
Okay, thank you so much for clarifying these points. There's one question here in the chat which I'll go to Dr. Khanna maybe, or Dr. Sharuna if you want to pick up. Would health insurers be providing or willing to cover diagnostic tests for HIV? For example, HIV testing. Would insurance be willing to cover that? And now that, as you know, HIV self-testing is also becoming available, do you recall any interactions where that would be a possibility? So please come in, Dr. Khanna or Dr. Sharuna.
Perhaps I will take it, Sharuna. So for coverage of diagnostic tests, One of the people we interviewed, person with HIV whom we interviewed for this study, he had worked previously in a country in Europe. And in that country, they provided an insurance policy, and this policy covered for HIV all the treatment costs as well as investigations and any tests done. So he actually managed to carry the policy when he came back to Malaysia, and he continued. So there are policies that do cover for tests as well as treatment for HIV. I think the thing is for the pool to be large enough for the company to be able to absorb that cost. But also another point to raise is that treatment of many other chronic illnesses are actually much more expensive now than comparing to treatment with for HIV, because it's a chronic disease. And treatment is very reasonably priced. And once the viral load is suppressed, the lab tests are done very far apart, once in 6 months, once a year. So the costs are very manageable.
Thank you. And I'll read another question, which is important for you to address. Did the study assess the limits of coverage, which are sometimes so low? What exactly are insurers covering? ARVs, imaging, opportunistic infections, lab tests, etc.?
So this is a question that has come up a number of times. In the first place, in Malaysia, most insurance companies don't cover. But my understanding of insurance companies overseas, some of them do cover. So what do they cover for if treatment is free? If treatment and management are done at the government hospitals. So any other illness that a person has can be covered. Like some of the people we interviewed, one had a fracture for which they went to a private hospital, and they managed to claim because this was the same person who had the policy from overseas. He managed to claim. But there are other people who don't disclose their HIV status, and then they managed to get treated for the fracture. Another example is in Malaysia, dengue fever is endemic. So people who have dengue fever, they can access treatment in private hospitals. Now, for people living with HIV in Malaysia, treatment is offered in government hospitals for free or at a highly subsidized cost. But for many people with HIV now are able to afford insurance, and even some of them are willing to pay a little bit more premium, you see. So if this is denied, there's an unnecessary burden to the government healthcare system for people who can actually afford to pay and then get treated in private hospitals, pay for an insurance and then get treated in the private. So I think this is an important point that should be emphasized.
Yeah, thank you. Thank you so much for stressing on this particular point. There's one more question that I will read out, and because I feel it's important for everyone to hear the answer. And this is a question about how in countries where private insurance is covering people living with HIV, how affordable is the premium in your assessment in this study?
So in the insurance companies that we did discuss overseas, like in North America, the company did their own studies of people on HIV and the treatment outcomes. And therefore, they designed policies like life policies, medical policies. But because the number was low, they put a lot of restrictions, like the person had to be viral load suppressed on treatment for 1 year, things like these. So then, although there was a premium, it was not a high premium. But it also depends in the pool, like, for example, in Africa, where the number of people with HIV are very large, and almost everybody is eligible for this. So then the premiums may not be as high as we would assume. And this was expressed by one of the companies locally as well. They said if we were to provide coverage by ourselves as the only company, then we would have an unnecessary burden because everybody with HIV would come to buy policies from us. But if it was a policy, a national policy that all insurance companies will cover, then the risk burden is spread out. And therefore, I would assume that the premium would not be as high. As I said, how can it be higher when many chronic illnesses that are covered by insurance policies don't require such a high premium?
Yeah, exactly.
and the cost of those are actually more than HIV today.
But having said that, I think we also found that there is a higher loading in terms of the policy for people living with HIV, but we don't have the exact figures. I think that also differs from country to country.
Thank you, Dr. Sharuna and Dr. Kana, for answering these questions. I think we picked up some of the main questions, but please take a look at the chat box. I would also invite Professor Adiba and Manuela to make a 1-minute intervention because they have heard it. If there's something that came to their mind, and maybe David as well, what is that one thing that stuck you and which you would like to stress as kind of your statement to contribute to these deliberations, even as a matter of recommendation that we heard. So who likes to go first? Maybe Professor Adiba, you'd like to take the floor, please? You can unmute yourself.
Yeah, sure. Thank you, Afsar. So practically for Malaysia, the importance of this report is, as you heard, so that we can remove, or so the insurance companies will remove the exclusion criteria for HIV. Even though HIV treatment is provided free for the government, but people living with HIV also suffer from other illnesses, as you heard from Andrew and Kana. So at the moment, because they're excluded from insurance and they suffer from a heavy burden of out-of-pocket expenses for other illnesses. So it's not, the importance is not just to support them through their HIV-related illnesses, but for other illnesses as well.
Thank you so much. And that's why we always talk about not an exclusive insurance product or policy for HIV. We should ideally be talking about an all-inclusive insurance policy and an all-inclusive approach. We know in the beginning of the epidemic, some insurance products were developed, but they didn't sustain because they were piloted for a specific group of people. There was not a large pool. But if you include HIV in existing programs, policies of government, because we should not forget the role of government as well as private sector, then certainly it will be a very useful thing to achieve. So thank you for making this point. David, a quick note from you, anything that you found more interesting in this discussion, or maybe a point that you want to make, having heard all the deliberations?
Yes, indeed. Thank you, Afsa. I think the first point is what Andrew said, that people living with HIV are living longer and healthier lives. So medical insurance cover is one important area, but it's not the only ones. Cover, for example, life cover and other insurance cover to really manage risks are important. Maybe another important point that I would like to emphasize is that insurance is a market, and like all markets, it has failures. And I think in the context of HIV, one potential failure I see, and I think which has been alluded to, is that insurance rarely covers prevention services, for example, for condom use, for harm reduction. So that is a gap, and this is where I think we will need government intervention to see if those areas can be subsidized. Maybe provide coverage for those services to the insurance that you get reimbursed for every person that you provide these prevention services for. And I think the last is really just to thank you, Afsa. You have been working extremely hard on this, and it's really such a pleasure to see this coming to fruition.
Thank you, David, for your remarks and highlighting the fact that the coverage should go beyond treatment It should look at prevention. It should look at diagnostic facilities. Then only we will be able to make achieve more out of it. Thank you so much. Now I would invite Manuela to come in and make her point, and Manuela, thank you so much for staying through this discussion, because it's been, I'm sure you must have enjoyed listening to this discussion. The number of things have come up, which I'm sure would have stuck you, but there's 1 point or 2 points that you want to make. Would like to hear you. Thank you.
Yes, well, first of all, it has indeed been a very rich discussion. I had a meeting at 10:30. I have sent a message saying that I would be 5 minutes late, because indeed I very much valued and learned a lot from indeed the findings of the research and contributions from other speakers. There are 2 messages that stuck with me. One is indeed how early diagnostic combined with proper ART and with the addition of health insurance may indeed enable people living with HIV to lead a full life and to achieve full inclusion. And the other issue is the business case that have came up quite strongly. Now, of course, perhaps the how can I say, the representativeness of the study is relatively limited, and perhaps further research may be required. But I think I found extremely interesting the comparison of what might be the cost for insurance companies of chronic diseases other than HIV, and hence the potential benefits that they could make if they could indeed open and expand the coverage to people living with HIV. So I definitely think that this is a line of research that would be worthwhile pursuing further in order to make an even stronger argument in support of the coverage of HIV by health social insurance. Thank you.
Thank you so much, Manuela, and thank you to all of you for participating. Thank you, Dr. Sharuna and Dr. Khanna, for making your presentations. I would also like to thank my colleague Didi Shah, who worked very hard with on this product all these months. And also, I would also recall Dr. Raghu, who worked with the Malaysian AIDS Foundation when we actually started this work, and he was there till the end when it was completed. He just left the organization because he found another job. But we should be always grateful to people who have been involved with us throughout. So thank you to all of them. I would, in summary, I would pick up only 3 points because we have discussed a lot, and in just less than 2 minutes when we close at 10:35, so that Manuela can attend her next meeting. So first thing is there's a strong business case that we have heard about it. Of course, we need to explore it more. The point here is, which comes across very clearly, that insurance companies are not fully aware of advances in treatment, and they're not fully aware that people are living longer, the point that we have heard today. So there is a lot of awareness raising that we need to do with insurance companies. And that's where this first action point, which is so important, because they would understand there's a business case when they see people are living and not dying. Because initially they were not covering HIV because they thought people would not live longer. So we have to do that awareness raising effort with companies, and this helps. We have seen it happening. When you bring insurance companies in a room and present these examples, get them to talk to Andrew kind of a person and maybe a doctor who is treating, they get convinced that this is not a bad business case for us. So that's one point. And it's also good to see that they are willing to cover, and that willingness to cover HIV is very good point coming from the study, and this is a good motivational point for us to talk to them more. Second point is about the group insurance of employers that has come up in the study, that even if there's a possibility, but employees are a bit reluctant to take that because of stigma and discrimination. They fear they might lose out on their promotional options if they have to go through a HIV test in their regular screening. Now, this is where I think we need to do much more work in promoting HIV workplace policies at the enterprise level. We have the ILO recommendation 200, which is making very clear recommendations. We keep doing it, but colleagues who are attending this call from our field would also stress that point more and more, to talk to companies and explain all the principles of workplace policy to them would be very important, because employer-led or employer has a very important role to buy insurance for their employees, and at least in the formal sector, that will work very well. The third point is the role of legislation at the country level, and the role of policy at the country level is extremely important. We have heard from Dr. Sharuna that Philippines, they had the bill that prohibits discrimination, and that became a very important factor for insurance companies to come forward, because insurance companies in whichever countries they operate, they have to look at the national laws, and they have to look at the national policies. So that's where the role of government is crucial. We also saw in Kenya. In Kenya, they have a non-discriminatory bill and policy, and that led to company like Jubilee and other to come forward and start including HIV. And this was very useful. So with this, I would suggest that we have quite a good recommendations and a body of evidence which will be useful for us to take this work forward. So I thank you all once again for your participation, and researchers for doing this study, in Malaysia AIDS Foundation for taking it up, and thank you so much for your willingness to take this important area of work forward. So with this, I close the webinar, and I thank you. This study is already on our website. I'm asking Didi to put it in the chat box so that you can click on this and share with your networks. And we will also be sharing it through our own channels, and that would be extremely useful for us to draw back on this important piece of work. Thank you very much. And with this, we can close the webinar. Bye-bye.
Bye-bye. Thank you.
Bye.
Namaste, everyone. Bye-bye from Nepal.
Bye, Rajesh. Thank you. It was very nice having you in the call.
Bye.
So bye.